My name's Emily. I think I know all of you, and this is Lacey. And we're here to talk about pharmacologic updates in diabetes for 2023. We gave this lecture or a similar lecture a couple years ago to this same group, but this slide deck has been maintained and updated throughout the years, mainly for our outpatient practices for internal medicine and family medicine providers. But I hope that you guys will find some useful information in this as well. I think major things and themes that you will see that have changed from the last time we presented this to this group is really how we focus on comorbidity management in diabetes patients. So we are not just targeting A1Cs and lowering those, but really focusing on complications that diabetic patients have that are disproportionate in the diabetic population than our other non-diabetic population. So we have no financial relationships to disclose. And all of the guidelines and images that we will be presenting today are available. And I'm actually going to hop out of here for just a second and show you guys some of the websites that are really helpful for providers as well as patients. I think they are some really good tools and images that can help us explain things to patients, explain the algorithms, show them in a stepwise fashion, how will we be addressing their diabetes, instead of just throwing a medication on, having them follow up and really not knowing what the plan is going forward. So I think that these can really help with some buy-in. So really quickly, let's see, we'll be talking about the standards of care in diabetes and the AACE guidelines. And I have these pulled up. The standards of care, I think, is a really great document. These were published in January of this year. And they're actually a pretty quick read. It seems like a lot of information, but they have different sections split up into different comorbid disease states, using technology to care for the diabetic patient, just general wellness and the approach to diabetes. And so these are really good, pretty quick read for each one individually if there's some aspect of diabetes care that you might want to focus on.
An abridged for primary care. It's like a 20-page overview of the bigger full guideline, and that's a great resource too for some quick references.
And then we also have the AACE guidelines that you'll see quite a few algorithms from these guidelines throughout the presentation. But here's let's see, one of them. They're really colorful. They update them just about every year. These are last updated in May of this year. And I think these are a really good way to discuss with patients from a provider to a patient standpoint. What is the plan? You know, if we do this today, when will we follow up? When will we check your A1C? When will we weigh you again? When will we check your blood pressure? And at that point, if things are still not controlled, where do we go next? And I think that getting the buy-in early on can really change the trajectory and the feeling of the patient towards treating their diabetes. So those are both available, and the links are included in the slideshow. A few learning objectives: review new guideline updates from the ADA Standards of Care and the American Association of Clinical Endocrinology. We'll explain new targets and monitoring parameters for diabetes, and focus on the use of technology in managing patients with diabetes. We'll describe pharmacotherapy options for diabetes and specifically for comorbidity management. And then we'll talk about a few things in the pipeline that we're pretty excited about to be looking for in the next year or so. This is the outline. It's pretty much the same. All right. And for anybody that's not as familiar with diabetes care, here are some abbreviations. Many of our drug classes get abbreviated in the literature. So here are those in case you want to look back. So as far as guideline updates, like I said, we'll be talking about standards of care, which were published in January of this year, updated just about yearly by the American Diabetes Association. And like I showed you, there are different sections, and it's split up really nicely. So if you don't have time to read the whole guideline, if you want to focus on a specific topic in diabetes care, they're set out really nicely for that. And AACE also has things set up very nicely in a bunch of algorithms. These were released in May. And one of the things that we will highlight throughout here is sort of how we've changed from our last topic, our last presentation with you guys. from treating people for an A1C goal to really focusing on complications first and foremost for our diabetic patients. So if you remember back probably to school or a few years ago, most of our patients, we would target an A1C of less than 7. And we usually use the stepwise approach. We would start patients on what we considered first-line medication, probably metformin, unless they had a very uncontrolled A1C, then maybe insulin. And we would do a stepwise approach. We'd bring them back in a few weeks to a few months, check their A1C again. Are you at goal? Are you not? Then maybe we would add on another medication. We'll highlight in a few slides our differences now. For people that have a very high A1C or are already experiencing complications, we want to target an A1C probably even lower. AACE recommends less than 6.5 or as close to normal as we can without causing too much hypoglycemia. And we want to do that early in the course of disease. So we're being much more aggressive early on to get to these targets. I'll hand it over to Lacey.
So, like Emily was saying, it's really moving towards lowering and getting as close to normal glycemia as possible. And so with some of these agents we'll talk about, we'll go through why we prefer some over some of the older agents. So this is one of my favorite slides and depictions of an A1C. The same A1C can look very, very different. So, and that comes in with the coefficient of variance. And as you can see in the one on the left, it's a very much more stable line, and the coefficient of variance is low. And then on the right, it is very much so up and down, and it is a higher coefficient of variance. So as we talk into some of the goals of like CGM therapy and some of our targets for some of those, we are going to target a smaller coefficient of variance so that we get a much more stable glucose values over time rather than having kind of a labile readings. So like Emily was saying, the overall approach has really changed over the past few years to be moving away from just focusing on just what their A1C value is to focusing on comorbidities. And the other change that I feel like has really come is being much more aggressive from the start with these patients. So not starting metformin for an A1C of 8 or 9, but really starting with 2 or 3 therapies to get quick control over that A1C value. Both of these guidelines have pictures that we'll go through on the next few slides, so I won't spend too much more time right here. So the ACE guidelines starts with a complication-centric algorithm. They also have a glucose-centric algorithm where you will see if you have none of these comorbidities, then you can move to that glucose-centric algorithm, which is probably what you're more familiar with previously. So everything right now, lifestyle is of course first line, will always be first line in these patients. But as far as when it comes to which medications to use and what therapy to add next, it really goes straight into comorbidities. So if the patient has ASCVD or they're high risk for ASCVD, you'll start with a GLP or SGLT2. Heart failure, you'll start with an SGLT2. Stroke or TIA, a GLP or pioglitazone. And chronic kidney disease, an SGLT2 or GLP. And then again, if you don't have any of those, then you can go straight to the glucose-centric. After that, you want to individualize their glycemic targets. And then if they're not at goal, start metformin if they're not already on metformin. And then if they're not at goal after the 3-month follow-up, then you'll add on their other alternate therapy for whatever comorbidity that patient has. So like I was saying, being more aggressive, the A1C now the ACE recommends that an A1C over 7.5, we're starting at least 2 agents, and over 9, or if they're 1.5% above their goal, then we're starting 2 or 3 agents. If their A1C is over 10 or their glucose is greater than 300 and they're symptomatic, you are going to start basal insulin and most likely a GLP. This is the glucose-centric algorithm. Of course, starts with lifestyle, and then this is maybe a little bit more familiar, starting with metformin first, and then getting to the individualized glycemic target, determining that, and then really determining and targeting what the biggest barriers for that patient is. So is it being overweight or obese, having a high hypoglycemia risk, access or cost of medications, or if they are presenting to you with severe hyperglycemia? And then you can see the preferred agents. For obesity would be a GLP or a GIP-GLP. Hypoglycemia risk would be a GLP, GIP-GLP, or SGLT2. And access and costs are thiazolidine dienes and sulfonylureas continue to be the most affordable options for our patients with diabetes. And then severe hyperglycemia, you're going to be starting either a basal bolus regimen or a basal insulin and a GLP or GIP-GLP. And then you can see your next step therapy and the alternatives, and then which agents in the red you would likely not use based off of their risk weight or obese, because those tend to cause weight gain. So if after this patients are not at goal on maximally tolerated doses, so we definitely want to make sure that we're titrating up these GLPs and SGLT2s to their maximum tolerated dose, then you can go on to the insulin algorithm. And I'm not going to spend too much time on this, but it serves as a great reference for how to add on and intensify insulin therapy. For initial dosing based off their A1C, we usually go with 0.2 because it's on both and is pretty safe either way unless you have a frail elderly patient. And then really giving the patient instructions to do some dose titrations on their own outpatient, so that when you follow up in a month, they've taken your increase of 5 units to increase of 20 units safely based off parameters, and you've made more headway in getting their glucose under control. I'll also not go through each one of these in detail, but we'll kind of discuss some of the possible benefits of these agents. So what's in blue for the classes that we go throughout the presentation. But it serves as a great quick reference to know if something is beneficial or harmful in a certain disease state. This is the ADA Standards of Care algorithm. It is very much similar to the comorbidity-centric algorithm that the ACE has, and does go into a little bit more depth on the actual algorithm about certain medications to use. So I'll draw your attention over here for weight management. It gives efficacy of our GLPs in high efficacy, very high, intermediate, and neutral. So kind of gives you a little bit more guidance on which medications to actually choose for what you need. This algorithm, I know you cannot read it, is also from the Standards of Care, but really kind of offers a stepwise therapy of which to add next. And I really wanted to point out this specific area that was previously that's on that previous algorithm that says to consider GLP or GIP-GLP in most individuals prior to insulin. And that's really because the trials that compared injectable GLPs to people who were on insulin that needed additional glucose lowering, the GLPs were just as effective and had less risk of hypoglycemia, and also patients had more weight loss. So that is why that has holds a higher recommendation currently. So that was a very quick overview of the guideline updates. We have come to our first self-assessment question. What is the first line medication for treatment of diabetes? We did not give options, so somebody has to talk. Yeah, so both are right. So metformin and depends on their comorbidity. Exactly. So it depends on their comorbidity, and then from whichever comorbidity they have, then you will decide. And if they have no comorbidities, then you go to metformin. Before I go into continuous glucose monitors, do we have any questions about the guidelines and which therapies to use? Yeah. The question was the variance that we were showing. Is there a laboratory measurement for that? No, not like a blood draw laboratory measurement, but there is, we get that data in with the CGMs. They calculate that for us, and another reason why they are extremely useful, because no, you will often not get their highest and lowest by checking. Even if you did 4 finger sticks a day, you're missing those postprandial spikes and potentially those middle of the night lows. Questions? Okay. So this is one of my favorite things to probably talk about is continuous glucose monitors. Historically, they have really only been used in type 1 diabetics and patients that are on continuous subcutaneous insulin infusions or insulin pumps. And then it kind of migrated to people that were on basal bolus, multiple injections per day, were slowly able to get these for type 2s. And then it's really kind of progressed that insurance is starting to cover them for 1 insulin injection a day, or if patients have hypoglycemia risk that's been proven. So it's really exciting time because these are something that our patients ask us about. They are not as siloed into endocrinology anymore. It's really become a primary care, really become popular among primary care, and our patients are coming in asking about these. So there are 2 types of continuous glucose monitors. There's personal and professional. So personal, there are 2 types of personals, real-time and intermittently scanned. Real-time CGMs automatically update to the receiver or the app on the patient's phone every 5 minutes. So that person is getting a new blood glucose reading every 5 minutes, whether or not they want it, it comes. There is alerts that you can set up on these that can show an impending low. So if someone's expected to be low in the next 30 minutes, it can alert them before so that they can self-treat before they get to that level. Intermittently scanned are, it measures your glucose continuously, but the patient has to actually move the receiver or their phone app over the device to get a reading. These are great. They don't get that immediate feedback unless they're actually scanning, which is a barrier sometimes. But you still, as long as they're scanning 4 times a day, you will get a 24-hour read, but they only store so many hours of data and they have to continue to be scanned in order to keep that continuous line. For a professional, these are devices that a clinic would own. So we would own the one of the sensors for one of the CGMs and put it on a patient that comes to an appointment if maybe their insurance doesn't cover it outpatient, or we're curious if they're getting low at night and we want to have more data. And these are worn for 10 to 14 days. The patient comes back, we can download the information and then make medication therapy decisions off of that. Professional ones can be blinded or unblinded. Blinded would be to where the patient does not see what their numbers are throughout that time. And then unblinded would be where if they could download the app, they can follow their readings throughout the time that they're wearing the sensor. There's pros and cons to both because patients do get immediate feedback and know, oh, I ate this. Now my glucose is this. I'm not going to do that again. And so it might skew results slightly. I briefly mentioned insurance coverage a few minutes ago. It has been one of the biggest hurdles in getting these to all of our diabetic patients. Most commercial insurances are covering the continuous glucose monitors. They are filled for commercial insurance at a retail pharmacy, most likely with a prior authorization, and most likely needing to be on at least one dose of insulin per day. Not injection, so GLPs do not count for that. It has to be insulin. And there are self-pay options set for sensors. So somebody, if they have the prescription, can go pay out of pocket for it at the pharmacy. We have some patients that do that and maybe only wear it for one session a month. So they might not have it on all the time, but they're fairly controlled. They want to see what certain diet is doing for their glucose control. And so they'll wear it for 1 week, not wear it for a week. And that way it kind of lasts a little longer, but they can still get the feedback that they need. And then Medicare and Medicaid, those are prescribed through DME, supplier that can be done online, or you can fax order forms. Medicaid is still requiring 3 insulin injections per day. Medicare, just in the spring, has lessened their requirements to insulin treated. So that counts for just 1 insulin injection per day. Or if they have hypoglycemic events, and there's 2 hypoglycemic events that can qualify them. If they have readings less than 54 on 2 separate occasions after medication therapy adjustments in between, or if they have a level 3 hypoglycemic event, which is less than 54, and they needed a third party to help treat their hypoglycemia, those patients can get one covered through without being on insulin. So this is adapted from the Dexcom website. It is not set in stone. It is their information, but we have one reason primary care, not just for the fast information that you get from these, but it is a billable service. So you add on that service charge to a regular office visit, and you can charge for the setup and training of personal devices. If you have a professional CGM, you can charge for that, and then you can also charge for CGM interpretation, and you can charge for the CGM interpretation once a month. So I know y'all are not as familiar with reimbursement and RVUs, but this is significant for as what would be considered an add-on to a visit. So I cannot talk about CGMs without mentioning drug interactions. There are some drug interactions. It's not worth memorizing, but do note that some substances can interfere with the readings. It's not influencing the actual patient's glucose value, but influencing what the reading on the CGM says. So if you have a patient's A1C that doesn't match up with their CGM when you download it, or someone's telling you their finger sticks are always this and their CGM is always reading this, then it's probably worth doing a little bit of an investigation to make sure that there isn't a drug interaction. Here are the CGM metrics I was talking about a little bit earlier, specifically wanting to talk about glycemic management indicator and glycemic variability 4 and 5. The glucose management indicator is kind of what comes up and what's equivalent to the A1C of that time frame that data is for. So you are downloading data for either 10 or 14-day period. You can add time in, but mostly what you're downloading is for that short period. And then the glycemic variability, as we were talking about earlier, really staying under that 36%. So the ADA Standards of Care and the ACE kind of have the same targets from previously. And then time in range is really what we're focusing on. So we want that above 70%. Time in range is associated with risk of microvascular complications. So the increased time in range, the decreased risk of microvascular complications. So we're targeting 70 for most patients. For very frail elderly patients that you're worried about hypoglycemia, it is acceptable to go down to 50 if you are having to do that to avoid hypoglycemia. And real quickly, this is kind of an example of what you see when you download data. You can get a lot of information. This is their time in range. So they're very high, which is over 200, 20% of the time, and they're high, which is over 180, 24% of the time. And we know our goal is less than 25 for these. They're in the target range of 70 to 180, 46% of the time, and our goal is 70. And they're getting lows 10% of the time. So this person has a pretty wide variation of blood sugar readings. And you might miss that if you're only checking fastings. So their fastings most of the time look pretty good, but you're missing this overnight lows without having kind of this continuous data. This is the glucose management indicator and their variability, which is higher than what we would want. Our patients in general have really liked having these. The instant feedback really helps them determine what foods are causing those increases, and has really become kind of, they self-report. They're like, well, I did this and I got to change to do this and I've got to change to do this. So it's been a great advancement overall for diabetes care for type 2 diabetics. So is continuous glucose monitors associated with increased time in therapeutic range? Yes. All right, and Emily is going to start off with the comorbidity management.
Okay. All right, this will be part 3-ish of our topic. These are slides that you guys have probably seen before, studies that have been talked about pretty extensively, at least as far as cardiovascular disease. But we are expanding, as you can see in the guidelines, targeting comorbid states outside of just cardiovascular disease. So I will talk about cardiovascular disease and then NASH, and hand it back over to Lacey to finish up. I think we've left cardiovascular disease at as the first comorbid disease state to talk about, because our diabetic patients have such a disproportionate complications with cardiovascular disease above that of our general population. So heart failure occurs up to 22% of all patients with diabetes, which is 4 times higher than that of the general population. We see twice as many heart failure hospitalizations in our diabetic patients. And atherosclerotic cardiovascular disease is one of the leading causes of morbidity and mortality in our diabetes patients. And so, as you can see in the guidelines, taking cardiovascular disease very seriously, they are addressed specifically in each of our diabetic guidelines now as one of the things that we should be focusing on at every single visit, and at least yearly, we should be assessing risk. So the standards of care in AACE not only address how to manage diabetes in patients with cardiovascular disease, but also address cardiovascular disease as a whole. So they both have blood pressure goals. For most of our patients, it'll be less than 130/80. We can consider some tighter control in our very high-risk patients, and looser control if patients are already experiencing autonomic dysfunction, so if they've had longstanding, very uncontrolled diabetes. They also both address lipid management, and I will pull up the AACE lipid management algorithm in just a moment, as well as the hypertension algorithm. But the pendulum has kind of swung as far as lipid management. Back when I was in school, we were targeting LDLs in our very high-risk patients of around 70. And then we sort of got away from that for a few years, just trying to get patients on a statin at all. So a high or moderate intensity statin, depending on their risk. And the pendulum is kind of swinging back to more of these specific targets and even lower LDL targets in our patients that are at extremely high risk or have had events. So even down to 55. And I bring this up because I think it's very important to know when to add on therapy and for primary care specifically, who these slides were originally written for, to be comfortable adding on therapy for lipid lowering. So PCSK9s, which were originally sort of isolated to cardiology, have now been really adopted into primary care in practice because it is very difficult to get an LDL down to 55 on just a statin. So increased utilization of medications outside of specialty areas too, which I think is really telling on how important this is for all of our primary providers to be aware of. So here is hypertension algorithm. Once again, in patients that are well above goal, so if they're over 160 systolic, we are going to go ahead and start 2 agents, much like if we have a very high A1C. Targeting these goals early on, we know is very beneficial. And here's sort of an algorithm as far as medications to add. And then likewise with our lipid panels and algorithms as far as adding on a statin and then additional therapies. So if you look specifically at guideline recommendations for cardiovascular disease in our diabetic patients, we're really targeting getting patients on an SGLT2 with proven cardiac benefit or a GLP-1. And likely in most of our uncontrolled patients, a combination of these medications would be recommended. And so you can see kind of depending on the comorbid states that the patient has, which ones we would prioritize first versus second. I think this is really helpful just to prioritize these medications because we do know that they have significant benefit for these patients. So we'll go into a little bit of pharmacotherapy here, pharmacology. So our SGLT2 inhibitors act by increasing glucose excretion in our urine. So we're blocking the reabsorption of glucose back into the blood. We know that we've seen in studies that this can also decrease blood pressure and promote weight loss. And we will talk about some of the renal benefits that we've seen in our studies as well. So here are the 3 with proven cardiac benefit: empagliflozin, dapagliflozin, and canagliflozin. And the highlights, the little stars right there, are next to our heart failure or diabetic kidney disease doses. I think you guys are all probably somewhat familiar with some of these studies, at least from the previous talk that we did. But I will go through them quickly. So IMPAREG came out first, and these are a little bit older studies now. But IMPAREG, the original trial, was looking at type 2 diabetic patients at high risk or with established cardiovascular disease. And we saw a decrease in heart failure hospitalizations. And we also saw a significant reduction in death from any cause, which I think was very exciting for the diabetes population and providers treating diabetes, because this is one of the first medications that we had outside of metformin that was really giving hope for morbidity and mortality benefit. Following the IMPAREG trial, because of the decrease in heart failure hospitalizations, we have looked at the IMPER reduced and IMPER preserved, which did include some diabetes patients, but also included non-diabetic patients. And we see these same trends in outcomes hold true no matter if the patient does have diabetes or has heart failure across the spectrum of ejection fractions. Dapagliflozin was in the DECLARE TIMI trial was set up very similarly with the 3-point MACE outcome. And we once again saw a decrease in the composite of cardiovascular death or heart failure hospitalizations, really driven by a decrease in our heart failure hospitalizations. And once again, in the DAPA-HF and DELIVER, we have looked at using these across the board in different ejection fractions in patients with or without diabetes, and these outcomes hold true. And then finally, the CANVAS trial looked at canagliflozin, and we saw a decrease in the composite outcome of the 3-point MACE, but the individual components were not significantly different. So across the board, we're seeing decrease in heart failure hospitalizations from these medications in diabetics and in non-diabetics. some considerations to make and some things to look out for. Most of the, we do consider these a diuretic. And so patients, we can see a drop in eGFR initially when starting an SGLT2. However, that's usually transient and overall can have really good benefit in chronic kidney disease or diabetic kidney disease. However, I do shy away from starting them in the inpatient setting in patients that are experiencing acute kidney injury or are at high risk. In most of our studies, we did see an increased risk of infections, so genitourinary fungal infections, and to a lesser extent, urinary tract infections. And I think one of the biggest, most important things that we can be aware of is DKA or diabetic ketoacidosis. It's kind of a unique situation for SGLT2s. We're lowering plasma blood glucose. And so in turn, your body is releasing less insulin and actually sending your body into a ketotic state, although your blood glucose is a normal level. And so I think pharmacy has played a huge role in sort of recognizing this adverse effect called euglycemic DKA and alerting providers like, hey, this is something that we need to be aware of in these patients that have come in on these medications because it can be overlooked, I think, pretty easily without the severe hyperglycemia normally associated with DKA. All right, and finally, our GLP-1 receptor agonist. So GLP-1 receptor agonists our GLP-1 is synthesized in the small intestines. It stimulates glucose-dependent insulin secretion, which decreases glucagon secretion. And one of the major side effects of this is slowing gastric emptying and having increased satiety for the patient. So in this way, you can see how it would promote weight loss and relatively low risk of hypoglycemia, as highlighted in our guidelines, preferentially using this over insulin in many of our patients if we're adding on an injectable agent, just because of the safety of that. GLP-1 is located really throughout the body, not just in the gastrointestinal system, but also in the brain and the heart. And so I think this is really telling as we get more and more information and as we use GLP-1s in more patients, I think that we will expand on the benefits that we realize by using some of these medications. These trials were very similar, so for the sake of time, I will not belabor them, but the LEADER trial looked at liraglutide in cardiovascular outcomes and saw a benefit driven by a difference in reduction in cardiovascular death. Dulaglutide, or the REWIND trial, looked at very similar outcomes, and this reduction in cardiovascular events was driven by a reduction in non-fatal strokes, as seen similarly to the Somaglitide trial. And so once again, we're seeing major cardiac benefits from these as well, not necessarily for heart failure in this situation, but for ASCVD events. Some considerations to make when using or starting a GLP-1. We do see increased risk of pancreatitis. So I think that's definitely something to be aware of with your patients if they've had pancreatitis, if they're at risk. Really teasing out sort of what is the etiology of the pancreatitis. Was it gallstone pancreatitis that they had a cholecystectomy for? Probably still consider a GLP-1. If they're actively using alcohol and they've had bouts of alcohol-induced pancreatitis, this might be something you want to hold off on for a while. So I think this warrants a discussion with patients. Another complication that we've seen due to rapid A1C correction in some of the original trials was increased risk of retinopathy. There is an ongoing trial called FOCUS that I think that will shed more light on this. Unfortunately, it's not due to be out until like 2026 or something. So more to come on that. I think one of the main things that we see, at least on the inpatient side, is gastrointestinal side effects. This is often seen when initiating therapy and or escalating therapy quickly. So a lot of these patients will have nausea, vomiting, diarrhea, constipation, runs the gamut of side effects. And so it's something to work through with patients, either slowing the titration, just explaining to them kind of what we can expect going forward. I think these are really important things to be addressing on the front end, just to kind of make patients aware. All right, and finally, this is my last few slides before Lacey takes back over. There's been increasing data and approach to managing patients with non-alcoholic fatty liver disease, or NASH. Currently, guidelines recommend lifestyle modification. So for most patients, weight loss of at least 5%. We don't have any FDA-approved medications specifically for NASH, but early intervention is key. And we do have some pretty good data from some of our diabetic medications and reducing or sort of changing the trajectory of patients with NASH. So first we'll talk about GLP-1s. They improve liver enzymes and histology and also cause a robust weight loss. So kind of killing two birds with one stone. They looked at liraglutide and semaglutide, and both showed significant weight loss and then lower rates of fibrosis and progression in the GLP-1 versus placebo group. And then finally, thiazolidine diones, a medication that we really have gotten away from in recent guidelines, has sort of had a resurgence. As far as treating NASH, we know that it can improve insulin resistance and improve glucose and lipid metabolism. So a medication that we typically didn't really want patients on just because of fluid retention and increased risk of heart failure exacerbations can be very beneficial in the right patient to help with some of this fibrosis and inflammation secondary to NASH. So patients that were on it saw significant improvements in steatosis, inflammation, and ballooning, and insulin sensitivity. So exciting things because we don't really have a ton of medications indicated for NASH, but it is pretty severe disease state for patients and concomitantly seen with diabetes frequently. That's it.
All right, we'll finish up talking about obesity and diabetic kidney disease. So obesity, we know that weight loss impacts on this disease state are vast. If you can really decrease A1C by decreasing at least 10% of your body weight, decrease risk of cardiovascular vascular outcomes, increase quality of life, mortality. It is important to note that in all patients, lifestyle modifications are first and foremost the most important, and then you can add on pharmacotherapy in addition to lifestyle modifications. So the ADA Standards of Care really has a whole section in here to consider medication impacts on weight. That's diabetic medications and non-diabetic medications that the patient's on. So if they're on steroids or antipsychotics, antidepressants, trying to find a more weight neutral option. And then listed are the approved medications for weight loss. Again, great chart, easy to use, easy to reference from the ACE guidelines. And it really gives a profile for all of our weight loss medications. And you can see that you can get pretty significant weight loss reduction from the semaglutide up to 15 to 18% as compared to even liraglutide or some of our other agents that are in the guidelines. I will note here that the weight loss trials specifically, we did see a higher percentage of weight loss than we did in the diabetic trials. In the weight loss trials, they were doing very, very strenuous diet and lifestyle modification, education and treatment teachings for those. And that is not as strong in the diabetic trials, which is why some of those percentages differ a little bit from the diabetic trials. So our GLP class has the most robust weight loss. Semaglutide and liraglutide are indicated for weight loss independent of diabetes status. So patients that do not have diabetes but would like to lose weight can still be on the semaglutide or liraglutide. The dosing for semaglutide is 2.4 for weight loss, and the max dose for diabetes is 2 milligrams, and liraglutide is 3 milligrams a day for weight loss, and the diabetes dose max is 1.8 milligrams. I did want to mention tirzepatide. I'm sure you all have heard about this medication, our GIP-GLP. It's not specifically approved for weight loss. It is right now a diabetic medication. In the trial, they compared their weekly dosing titrations to 1 milligram of semaglutide. and did see improved glycemia of over 2% decrease in A1C, and more weight loss in the tirzepatide group. However, from the previous slide, if you remember, the max dose for semaglutide is 2.4 for weight loss and 2 for diabetes. So not quite apples to apples on this. And I really hope that if we see one comparing the 15 milligram to the 2.4 to kind of get our answer of the weight loss efficacy for both of those. Real quick, we will go into diabetic kidney disease. So glucose lowering to near normal glycemia does help delay the progression to DKD and the risk for albuminuria. And so we talked about some of these trials, and we'll go into that were specifically for cardiovascular outcomes and then for our SGLT2 class, but showed some positive renal outcomes in their secondary analysis. And so we now have trials that are specifically just for kidney disease. So DKD, the standards of care and the ACE guidelines have SGLT2s and GLPs as first line. You'll notice that you can use them down to a creatinine clearance of 20. It is important to know that if these are used as a diabetic agent and kidney protection, you will lose the glycemic benefit at a creatinine clearance about 30 to 35. So just knowing that you will keep them on for kidney benefit, but you will lose that glycemic effect. And then there is a new medication that the standards of care is now in the standards of care for this update in January. It is a nonsteroidal mineralocorticoid receptor antagonist, or Phenerative, and we'll talk about more in a minute. So these are our DKD trials for the SGLT2s. You'll see in the Credence and DAPA kidney that all of those patients were on an ACE and ARB at baseline. And then when you went to IMPA kidney, about 85% of these patients were on ACE and ARB. So we're still keeping ACE and ARB. We're not necessarily replacing that with the SGLT2 class. And then you'll notice in the Credence and that all of the patients were diabetic patients. And as we move to DAPA CKD and the IMPA kidney trials, that we get down to less than half of the patients were diabetic. So we're seeing these benefits overall in patients that are not diabetic with this drug class. So similar to the GLPs being used for weight loss and NASH, independent of diabetes, we're also seeing these being used for CKD. For the GLPs, liraglutide in the LEADER trial was all patients with diabetes, and they did show a secondary analysis that had positive renal benefits, and that was mostly driven by the reduction in development of albuminuria, which is similar to the REWIND trial with dulaglutide. Of note, 82% of the patients in both of them were on an ACE or ARB. And that really leads us to the FLOW trial, which we will see it is with once weekly semaglutide, but those results are not quite out yet. They're wrapping that one up, and we'll have them hopefully next year, but likely showing that this is more of a class effect for preventing progression to new albuminuria. So finerenone is our nonsteroidal mineralocorticoid receptor antagonist, and the ADA standards of care recommend that it is used to decrease chronic kidney disease progression and cardiovascular events in patients who are at an increased risk of CKD progression or cardiovascular events who are unable to take an SGLT2. So currently its place in therapy is behind the SGLT2s as far as renal protection, but is still giving us an option for patients that can't tolerate ACE and ARB and can't tolerate an SGLT2. We have our next option for kidney protection. So in conclusion, we think that the SGLT2 impact on DKD is really a class effect. We're seeing positive renal outcomes in both our non-diabetic and diabetic patient population. And really that we get more robust results at that lower GFR. So we are continuing these on until they get to a creatinine clearance of 20 or they're on dialysis. Reminded that we do lose that glycemic benefit at that low of a GFR. And then we do have another option with our Phenerative recently out, and I think we'll see more about where its place in therapy is in the near future. Self-assessment question number 3, what class or agent is recommended for treatment of obesity and NASH in patients with diabetes? Yeah, GLP-1s, specifically semaglutide. So real quickly, talk about a few things that are coming. Long-acting insulin. So there are 2 insulins in trials, insulin icodec and basal insulin FC, and these are weekly insulins. So what you will see is that they are going to be in combination with a weekly GLP and a weekly insulin. Preliminary and phase 2 studies have not shown an increased risk of hypoglycemia events, but will be very important to know if your patient has just taken one of these the day before they came to the hospital. So knowing that that is still going to be in their system for the next 1 to 2 weeks easily. And then oral semaglutide. Currently its doses are 3, 7, and 14, with 14 being somewhat equivalent to 0.5 of the injectable semaglutide. And injectable semaglutide for diabetes goes to the 1 and 2 milligram dose. And currently the 25 and 50 milligrams are being developed in order to kind of be more equivalent to that 1 and 2 milligram. This is the only oral GLP option that we have. All the rest are injectables. So in conclusion, glucose monitoring is changing to really continuous glucose monitors. If somebody can get them, we want them to have them. Really changing to overall trends in time and therapeutic range versus an A1C value. And the focus of diabetes care in general has gone to really preventing comorbidity complications associated with the diabetic disease state. And then there's some neat new and upcoming medications, trials that'll be coming out. And so it's an exciting disease state for constantly having new information and more options that will benefit these patients. Do y'all have any questions? Yes. The question was, would you recommend resuming a Frozen after a patient experiences euglycemic DKA? Right.
I think a lot of it depends on the setting around which the DKA occurred. Is the patient versus and weighing the risks versus the benefits. I think that yes, we want to keep them on. I don't think it's a complete contraindication. Now, if the patient comes back again and again, then that, I think that would cause you need to pause on that.
We do treat it similarly with the mycotic infections. The first one we do retry after, especially if their A1C was elevated at time of initiation. So if you start it in a patient that has an A1C of 11, obviously they're going to spill more glucose than somebody that has an A1C of 8. So we, in general, don't start them until their A1Cs are closer to the 200. I mean, when their blood glucoses are closer to 200. And so we might hold off initiating them, even if the patient is indicated, just to hopefully kind of prevent that adverse effect. And then the patient being like, I'm never taking this medicine again. And you lose out on a really good class of medications for this patient population. Any other questions? Code. There's your code. Are you okay?